Observing the continuous movement of fluids through the gastrointestinal tract presents a specific physical challenge. Any highly invasive procedure risks disrupting the exact physiologic environment you are trying to measure. To evaluate the competence of the gastroesophageal sphincter without altering its natural behavior, clinicians rely on gastroesophageal reflux scintigraphy, often referred to as a milk scan. Barium swallows require dense, non-physiologic liquids that can alter normal motility. By using a standard liquid meal paired with non-absorbable compartmental mapping, a GER scan provides a quantitative model of luminal physiology under real-world conditions. Clinical suspicion for gastroesophageal reflux disease, or GERD, must be adjusted based on the patient's age. The clinical presentation is highly bifurcated between adult and pediatric populations. Adult patients typically present with heartburn, regurgitation, and a distinct epigastric chest pain. This pain is frequently severe enough to closely mimic stable angina or the initial stages of a myocardial infarction. Adults also experience secondary symptoms driven by the microaspiration of gastric acid into the upper airway, resulting in hoarseness, chronic cough, asthma, and persistent laryngitis. Pediatric patients exhibit an entirely different profile. Their presentation is dominated by respiratory issues such as recurrent pneumonitis and sudden episodes of apnea, alongside failure to thrive, iron deficiency anemia, and abnormal body posturing known as Sandifer syndrome. Across all ages, chronic untreated reflux leads to severe cumulative physical damage. Patients face a high risk of developing esophageal strictures, Barrett's esophagus, and eventually esophageal cancer. Physicians order a GER scan to secure objective data. The primary indications include assessing unexplained respiratory symptoms, especially suspected aspiration, and obtaining definitive evidence of severe reflux prior to committing a patient to anti-reflux surgery. The scan is especially critical for symptomatic patients who have already undergone an upper gastrointestinal endoscopy that returned completely normal results. Scintigraphy detects the dynamic failure of the sphincter that an endoscope often misses. Capturing accurate kinetic data requires strict patient preparation. Patients must be strictly NPO, nothing by mouth, for at least 2 to 4 hours prior to imaging, with adult patients generally fasting overnight. This diagram demonstrates the physical consequence of recent barium studies. If a patient ingested barium within the prior 48 to 72 hours, the dense contrast material absorbs the gamma rays, effectively hiding the radiotracer from the camera. Enforcing these physical and chemical parameters is non-negotiable. Failing to clear barium or selecting an easily absorbed tracer will directly invalidate the diagnostic yield of the study. The required radiopharmaceutical is technetium-99m sulfur colloid. It is the premier choice strictly because it is entirely non-absorbable in the GI tract, maintaining its full volume within the target compartment. Technetium-99m DTPA serves as a secondary alternative if sulfur colloid is unavailable. However, it carries a slight absorption risk of up to 2%, particularly if the patient's mucosal lining is currently inflamed from esophagitis. Standard dosing requires 0.3 millicuries for infants, which scales up to 1.0 millicurie for adults based on weight and feeding volume. The administration process involves mixing the precise dose of radiotracer into a standard liquid meal, like milk, formula, or juice, which the patient ingests orally or via an enteric tube. Immediately after ingestion, administer a cold chaser. This is a small 10 to 30 milliliter volume of non-radioactive liquid used to wash any residual tracer out of the mouth and down the esophagus, ensuring the starting baseline is clear. This schematic illustrates the chaser pitfall. Administering too large a cold liquid volume forces the glowing tracer straight through the stomach and into the duodenum. This premature emptying overdilutes the gastric pool, mathematically guaranteeing no reflux will be detected. Exceeding the precise cold chaser volume directly alters the physiological environment you are attempting to measure, instantly converting a highly targeted reflex scan into a useless gastric emptying study. The scan relies on the mechanism of compartmental localization. A radio tracer is ingested and physically travels down the esophagus and into the stomach. The crucial factor is that it remains strictly within the gastrointestinal lumen without being absorbed into the surrounding systemic tissue. This sustained visibility allows the reader to track three specific diagnostic targets: the acute or chronic retrograde flow of gastric contents back into the esophagus, the rate of gastric emptying, and the presence of pulmonary aspiration. To capture the luminal transits, utilize a large field of view gamma camera equipped with a low-energy parallel hole collimator positioned directly over the anterior aspect of the patient. The patient is placed in a feet-first supine position. The camera must be aligned so that the entire esophagus and the upper portion of the stomach sit squarely within the field of view. The camera captures these emissions using a 20% energy window centered exactly at the 140 kiloelectron volt photo peak. Phase 1 is the dynamic phase. Imaging begins immediately upon ingestion. The camera records rapid frames at 5 to 10 second intervals continuously for a full 60 minutes. Phase 2 shifts to static and delayed imaging. Once the 60-minute dynamic run concludes, a high-count 1-minute static image is acquired. Finally, an additional delayed image of the chest is captured at 2 to 3 hours post-ingestion. This specific image serves a singular purpose: evaluating for pulmonary aspiration. This extreme temporal delay gives the esophagus time to naturally clear itself of any residual tracer, ensuring that any persistent radioactive signals detected in the chest are specifically isolated to the lung alveoli. Interpreting the raw kinetic data relies heavily on qualitative visual assessment. The reader evaluates the cinematic playback of the dynamic phase, looking for distinct spikes of tracer moving retrogradely from the stomach back into the esophagus. The severity of these spikes is graded using Fisher's criteria. A mild grade describes reflux isolated to the lower third of the esophagus, scaling up to a severe grade 4, which indicates total oropharyngeal aspiration. To track therapy response, physicians calculate the reflux index, or RI. Maximum esophageal counts, ET, minus background radiation, EB, divided by initial gastric counts, G0. An RI below 4% is normal. 4% and above is significant reflux. The specific timing of these events matters. Reflux occurring late in the study, when the stomach has a low volume of food, carries higher clinical significance because the sphincter is failing without the pressure of a full meal. By applying the reflux index, clinicians replace subjective visual interpretation with the hard objective data required to justify invasive surgical interventions. Despite its accuracy for gastric reflux, standard GER scintigraphy has a major diagnostic blind spot. Its sensitivity for detecting pulmonary aspiration is catch-all only 1 to 25% of the time. Full comparison highlights the procedural difference required to fix that blind spot. When clinicians specifically suspect a patient is aspirating their own oral secretions rather than gastric contents, they bypass the stomach entirely and order a salivogram. The salivogram utilizes a microvolume of tracer, less than 1 milliliter of technetium-99m sulfur colloid, is placed directly onto the posterior tongue or buccal mucosa, allowing the patient to swallow it naturally. Rapid dynamic framing captures the immediate transit of this tiny volume. Clinicians watch directly to see if the tracer descends into the tracheobronchial tree, explicitly confirming the failure of the patient's airway protection mechanisms. Securing diagnostic accuracy requires exact mechanical alignment. The radiotracer delivery method must precisely match the physiological origin of the suspected aspiration. Readers must also account for distinct physical artifacts. When a patient lies completely supine, the proximal stomach can physically overlap the lower esophagus, creating an overlapping fundus that obscures the lower sphincter entirely. Severe diaphragmatic motion, such as a patient experiencing hiccups, creates sharp mathematical spikes on the data curve that perfectly mimic reflux. Readers must always correlate the curve with the raw kinetic imagery to verify the presence of actual tracer. Regarding dosimetry, the radiation safety profile is favorable. Due to the small administered activities, the effective radiation dose yields a total burden well under 1 millisievert. The dose-limiting organ is the large intestine wall. Because sulfur colloid remains completely non-absorbed during transit, the tracer eventually pools in the colon, where it maintains its longest residence time. Post-procedural safety measures are minimal. Patients can immediately resume normal diets, and breastfeeding mothers require no interruption. The tracer is eliminated via feces, requiring standard hygiene practices for disposal. While GER scintigraphy provides a direct, quantitative map of luminal transit and retrograde flow, its clinical utility relies entirely on the physician's ability to rigorously enforce protocol, control the testing environment, and separate true pathophysiology from simple mechanical artifact.